lasered it then and there itself, and then definitely lasering the intraoperative FA guided focal laser to the PNP area. So this probably is something which we have added to our armamentarium is by adding the 485 NM bandpass filter that it gives the cobalt blue light, the excitation filter. So here we use the intraopacity. It was showing a spongy edema. So immediately we shifted and did a ILM peeling. So that what I did was through the monochrome digital filter, which aids in doing ILM peeling pretty much easily. So now coming to the next bimanual surgeries, how we do that. In a situations like this, we have a bloody red situations of the retina. So what do we do in such cases? We use something called as the reduced red light. Now you can see here, I'm changing different filters. And now with one filter, you can definitely see these membranes sometimes kind of fluoresce, so that you can have a good differentiation between the retina and the membranes, and so as to have the lesser and less iatrogenic breaks. See, basically retinal surgeries, you need more and more good visualization, especially when there are bloody red situations, there is blood around, there is a complex membranes around. At that time, whatever helps the best in visualization, I think that will give the best results to the patient. Now you can see here, I'm using a bimanual technique with a chandelier. The membranes glow out pretty much well. And once it is done, you just eat up and finish the surgery. Now coming to the next is, I'll be showing. These are the few cases, you know, that very difficult in the perspective when it comes to. So I thought, let me show you some cases. So this is case one. So this is, I told you, Dr. Anurag told me to keep the audience engaged. I'll be making it with some animation. Something pediatric retinal surgery can be done, still have it right back again. So this one a closed funnel RD. So the challenge here was first to do a peripheral vitrectomy. And now you can see the posterior. So you need to get access to the posterior pole. Whether you do it with a cutter, whether you do it with a forceps, whatever best suits your hand. I'm just trying to peel as much membranes from the posterior pole as possible. Now you can see here, once I get access, now you can use the cutter itself to do a cutter segmentation and then inject PFCL. Now you can see those pre-existing breaks which are already there. The macula is still not fine because there are premacular membranes there. I had to delineate, I had to remove all these membranes meticulously. So once I start peeling this membrane, now you see how the starts unfolding. Definitely because of the anterior media, I had to do a retinectomy and then subretinal fibrotic glands, subretinal blood, whatever is there has to be removed. And once it is there, then you can see the free floating retina. That means it is devoid of any attachment. Then you inject PFCL, flatten it, do the laser. Now you can see a pretty well settled retina as much as possible because it was a closed funnel attachment. Now, coming to the next case two. Oh God, it's not the blistering these conditions. It must be almost impossible to drive up. This was another case of close funnel retinal detachment. Now you can see it's almost touching the lens, or it's almost touching the anterior part. So this, now the challenging part is sometimes these kind of retina, they unfold, and if it doesn't unfold, then the surgery is over. So always it has to be taken under guarded visual prognosis. So I could see the rim, the postal part of the rim was very much adherent. So I did a retinectomy, then the retina started floating. So that gave me a guidance, okay, this can open up. So after I did that, then put a PFCL. Now you can see the retina slowly starting getting unfolded after removing those fibrotic bands. Again, whatever are there have to be removed. Now you can see there's already toroidals also in this place. But definitely these are the extreme cases has to be taken under very guarded control. Whenever the patient asks anything about the guarantee, I say no what is guarantee in our dictionary. So as much as these And finally, see, relatively, I think this is what maximum I could settle in this case. But slowly it started unfolding later on, and that is how the patient had around conflict. It was a very bad case. Now I'll be showing the next case, again a closed funnel RD.
Don't ever let somebody tell you you can't do.
So this was the case where this kid got hit by a football and a tennis ball twice within 15 days. So again, unfast view shows closed funnel retinal detachment. Again, as I showed earlier, do a peripheral vitrectomy and now trying to open the funnel. So stretch it either longitudinally or laterally so that you get a good access to the posterior pole. And if there are any membranes, just definitely peel it so that it becomes easy for the retina to unfold. Then step-by-step PFCL injection is very, very crucial in these kind of cases. So as I went on injecting, I could see definitely more and more the bands which were not allowing the retina to unfold. And then finally, I'm removing most of these membranes. Again, as I said, add little more PFCL. Now I can see at least the posterior pole up to the arcades pretty much well settled. Now I thought up to the equator it is getting well settled. But yes, definitely there was some traction persisting. I was amazed why what is happening, why there is contraction. Then again I saw that there was more membrane. And this is what we call as the window of hope. This is a small area of rear cornea in this traumatic case kit. Finally, we could see beyond equator, the retina also settled well. And lasering the edges, retecting edges in these cases. And then doing a fluid air exchange. Yes, some people prefer to do direct PFCL silicone oil, but I love to do fluid air exchange and then to do a silicone oil exchange. It is less messier. So coming to the next set of cases, this was the case was admitted in a blind school. So yearly we do a blind school evaluation. So we thought again, let us take it as a challenge and let us go ahead. So initially doing a lensectomy in this case. So after doing a lensectomy, now you can see the retina just seen behind the posterior capsule. So here initially you have to do, you just need to create a plane here to access. And you can see the membrane was almost stuck. Remove as much as membrane, if not under the biome, but definitely under the microscope visualization itself, you can do that. And once we get an plane, then pass on the infusion, because sometimes if you go subretinal, it will be more and more damaging. So here you can see the retina thrown into multiple folds, meticulous, systematic vitrectomy, either with the help of the forceps, you can try to peel it, or with, if it comes well, with the help of the cutter, you can definitely remove as much as membranes as possible. So you can see here, after doing that, I did a fluid exchange. Now you can see the retina, the bullosity coming down. And then after injecting a PFCL, now you can see a pretty well settled retina. But again, the peripheral PVR has to be addressed. If the membranes can't be removed, then it's better to do a peripheral retinectomy. Otherwise, peel as much as membrane and try to preserve as much as retina as possible, rather than going for peripheral retinectomy. So these are few of the other challenging cases. And the good part of this is the child had some ambulatory vision and he is out of the blind school. He is now taken into the special school. So these are few of the things which you have some emotional content also in these cases. So these are the next case I'll be showing in few minutes is about the trauma cases. So this was the case of a traumatic this thing, and he was a tile cutter. Midnight he came at 12 o'clock. So this was the chip of the tile cutting blade. It broke off and it almost halved his eye. So I took it for surgery after 7 days. And these are this is the not very old patient. He is, I think, around 37 or 38-year-old.
The bad combination is the altered vitreous hemorrhage and the retinal detachment. And if there is no PVD, because inducing that almost both of them look similar. And in these cases, it's really challenging. So once we get an access to pull out these membranes, that is where you gain confidence. So here I had to do a peripheral retinectomy here. But again, you can see the PF cell entering the subretinal space, indicating that there is still persisting traction. So I had to do more incremental retinectomy. And finally, I could see settled retina, injecting the PFCL. And now you can see a pretty well. So this is the small window. We call it as a window of hope. We have operated such many cases on that using the 3D visualization machine, which we call it as the window of hope. So this is another case of foreign body the patient had, and then we thought that we could remove this foreign body as much as possible. So here I'll just go to the foreign body part directly. So these are the multiple pieces of the foreign bodies. So scleral tunnel was made to remove. I use a MVR blade to grasp this. So this is the claw forceps by Manish Bapai has devised it. And now IOFB1 was removed. And since only the bigger one, the irregular ones are best can be removed by these claw forceps. So now this IOFB2 being removed now. And then IOFB3, IOFB4, and then IOFB5. So I thought everything went well, and I then tried to settle the retinal detachment. But again, 2 more IOFB fell down. It was probably at the angles which was stuck, and IOFB6 and IOFB7. So total, there were 7 intraocular foreign bodies in this patient. And finally, we could remove all of those. Otherwise, these are the patients, metallic foreign body, they go in for siderosis later on. Initially, they might look good, but later on, they will go in for siderosis. Now, these were the situations which I was telling is, with the help of these 3D visualization, you have an increased peripheral visual acuity, which you can definitely go through and settle most of these cases. Now, I'll show some of the stories, interesting stories, which I'll show it. So this was a simple case, retinal detachment, wife of a lawyer, everything went well, but a subfoveal PF4 remained. So after 7 days, I took it up. The only mistake I did here was to do an ILM peeling. I'll tell you why. So I thought everything went well. Post-op, patient developed full thickness macular hole. Not just that, I asked them to get operated soon. They came after 1 week, it became macular hole RD as well. So the only technique left was to do an ILM transplant, because ILM was already peeled. So I thought I will just bring these ILM from the periphery and plug it into the macular hole. I used the intraopacity, everything was going good. Oh, what happened? Those ILM came up to the forceps. So once it comes out to the forceps, these free flaps, it will never go back again. Now add to that, the patient also developed choroidal detachment. So here I had to drain the CDs first, and the CD got resolved. The only choice left to me was to do a neurosensory graft technique. So here I first try to cauterize it and raise a 42 gauge bleb. Just try to raise the retina because you don't want to cut the choroid. So slowly try to either unimanually or bimanually try to cut that piece and then slowly stuff it onto the macular hole. You can use the intraopacity if you have. Just see that, and silicone oil was injected. This is 1 month post-op, and this is 4 months post-op. The patient improved to 6/24 vision in this case. So these are some of the cases. Everything was going fine. Something suddenly happens, and we have to be this full in this case. So this is another case where I'll be showing. Again, a subfoveal PFO was found in the surgery and was planned to remove the subfoveal PFO with a 38 gauge needle. So you can see this is the day 1, and a large subfoveal PFO what remained, and day 8. So my colleague sent this case to me and said, "Sir, let's remove it." So what I thought here was you have to use a 38 gauge needle to remove the subfoveal PFOs, right? So as I remove, but you can see there is a thick fold. And if I had put a gas, that fold would have remained as a fixed fold. So what I did here was how to unfold this. So we used the technique called as the macular detachment induction technique, which I learned it from my mentor, Dr. Lam from University of Toronto, where we have closed failed macular holes with this technique as well. So what happens inducing this detachment using a 38 gauge needle and then compressing it with the tamponade, it tries to iron out the retina. I'll show you here. The important step here is you should make sure that the macula is detached here. Otherwise, that technique will not work. It will still remain as a fixed fold. Now you see that once the fold is removed, the 1 week post-op, you can see the PFO is removed, and then later on, you can see there is a well contour, the fold is completely removed. So these are the few of the techniques how we can handle these. And this is another interesting case, which I thought I'll show it to you all. My colleague has named it as oil and gas, a bubbling story. So what happened here? So post pneumatic retinopexy, it is SF6 gas we had injected, went into multiple fish eggs. We are very surprised. It was only one single bubble when we had injected. But later on, in these cases, we had to do a vitrectomy because those gas bubbles went underneath the retina as well. So we have to do a vitrectomy and try to remove these bubbles. So most of these gas bubbles were removed. Everything looked fine. Lasered the brakes and then looked for any peripheral breaks. Okay, now everything is looking good. So inject silicone oil. Within 2 weeks, we could see the emulsification of the silicone oil. Along with that, the patient developed cataract as well. So I did a combined phacoemulsification and put a foldable lens. And then I had to remove this oil. You see this? It's looking like, I'll show you in a magnified view how it looks. It looks something like the crystals, no, diamond crystals. So these silicone oil bubbles were removed. The multiple fluid air exchange was done. And then we had to do an ILM peeling. And after that, I thought everything was going well. Put a air, the air also started bubbling. So this was called as the gas, oil and air, a bubbling story. So till today, we were not able, we have presented in multiple platforms, but we're not sure why it really happened. So this is my last case, show a subluxated SFIOL. So how we can fix it? If only one haptic is dangling. So here what it was to clear the vitreous around that dangling SFIOL, clearing the vitrectomy, doing a vitrectomy, and cut that suture remnant, what is there at the eyelid. That is very, very important. Otherwise, that is trying to rub the ciliary body and try to give more and more damage. So once we do that, here what I'm doing is use this dumbbell technique, what we have to surgery, a slight modification of that dumbbell technique. Use a 6-O-proline. So the 6-O-proline was injected into the hub or the lumen of this, and then 26 gauge. So externalize it. So once we externalize that, just flange it so that it doesn't slip down. Cauterize the external, then take the internal part, and then you can go into the vitreous cavity and then thread it to the eyelet of this SFIOL. The threading has to be done upside down, not downside up. If you do downside up, that bulb, what we call, it rubs the ciliary body. So the upside down, externalize the once you thread it into the vitreous cavity, and once you externalize it, make sure that you flange it properly. Otherwise, if it goes inside and slips, that thread is lost. So the bulb has to be big enough to hold that eyelet and pull it. Now you can see a pretty well-centered IOL. Just cut it and then flange it properly to show that there is a good penetration possible. And then push it back into the sterile tract. So this surgery, I think, got over in 22 minutes. 23rd minute on the left side. And see and do a looking for any peripheral breaks. So everything is going fine. This is post-op day 1. So thank you very much for your patient listening. Hope I could show some interesting cases, which I felt was interesting to me.
It is really extreme cases, and you have done extremely well in all these cases. The final word is like you never say no to anything.
Thank
Thanks,
you, sir.
Srinivas, for showing us these extreme cases.
Thank you, sir. Thank you so much.
Yeah, exceptionally good. So I have a couple of questions. So in case of a diabetic vitrectomy, in case of peripheral, as you showed, there are some peripheral tractional elements present. Would you like to do a cataract surgery along with the vitrectomy?
Madam, to be very frank with you, if there are very much tough membranes, then I don't mix both. I prefer to do a cataract surgery before and then do a retinal surgeries, because when we do the indented examination and all those things, sometimes we see the AC getting collapsed or the pupil becoming smaller. That irritates the posterior segment surgeon more. If it's a simple vitreous surgery, then both doing together has no problem at all. But very complex membrane, when you want to reach to the extreme periphery, then I prefer to give an anti-VEGF along with the cataract with IOL in the first phase, and then take it up for the surgery in the second phase. You just need to have a good AC is what I feel.
Have you experienced patients going on to NBI, developing NBI after the surgery of a combined surgery? If there is a lot of traction in the peripheral areas, the retina is very ischemic in the peripheral areas. If you combine the surgery, then probably patients would go also into NBI.
Okay.
Very soon. The other question that I had, do you use a reflux in peeling off these membranes?
Yes, madam. So basically, only I used to reflux the blood, but I don't use it for the visco dissection or all those things. I somehow felt that again it becomes more messier. So sometimes when we want to lift the membranes, use it, it becomes so. I prefer to either raise the infusion or do a cautery at those areas. But I have never personally used reflux with a visco while dissecting the membranes. Yes, with the fluid, definitely you can do. You can get a plane and then go ahead with that.
I was asking about the fluid.
Yeah, fluid definitely you can do, but not with a visco.
So any tips for knowing if it's an old vitreous hemorrhage, it's almost like a retinal detachment. So when you go inside, it's very difficult to recognize whether it's a vitreous layered with old blood or a
Or
retinal
the retina.
detachment. So what are the tips you would give?
Very important and very difficult question to. So I always tell my fellows, whoever started that or my colleagues, start from the periphery. If you cut the periphery. Don't cut the central retina. So once I get an access to the central core, after doing a little bit about the core vitrectomy, I always go to the periphery and then slowly start coming down to the equator. Once I know that, okay, so sometimes it so happened, my fellows telling, sir, choroid, sir, choroid. Is not allowing me to do surgery at all. The moment I start cutting, sir, choroid, there was no choroid at all. I'm not cutting the retinas. Actually, the vitreous hemorrhage which I was cutting. And later on, when we pulled it up, fortunately, I could get a PVD induction done and settle the retina, and everybody was surprised. So it's a very important thing to distinguish. Always keep looking for the blood vessel. And in that case, it was a post-end-off. The blood vessels were also not seen. It was completely sclerosed. So that becomes a little more challenging. Layer by layer, once we keep cutting it, get access to whichever, either nasal, temporal, inferior, superior. Once I see that, okay, the retina is visible, then I go ahead and do an abrupt PVD induction and then
Even if the blood vessel is not seen and you are cutting and it is bleeding, most probably you are cutting the retina.
Exactly.
Sir, very nice cases of all those closed funnel retinal detachments. But sir, one thing I want to, in a closed funnel RDC, sir, the prognosis is very bad, of course, and the success rate is less. I mean, sometimes you may have to abandon intra also. How do you say yes? I mean, you never said no, but how do you say yes?
After 40 years, I think life slows down. So before 40 years, we have that enthusiasm and to do that. Why I'm telling this question is, I'm seeing those kids now, hypotony, silicone oil left, the globe is intact. That's the only happiness what we got. And in that kid, he is counting fingers 1 meter, that closed funnel RD. So I think that's the only kind of happiness which we get. But these are the cases which will have hypotony later also. The ciliary shutdown is going to happen. These are the extreme cases. So definitely a very hard counseling is very required. Just presented, and Barokal was working on this, and she told me that we are giving false promises sometimes to these kind of kids. Because initially, intraoperatively, retina looks fine. We are happy. But later on, I think if it redetaches anything, then the patient will never be, no, he will have a band keratopathy and all those things. So it's like giving us false hope. But some cases it works. 30% of these cases I have seen out of my around 20, 25 closed funnel RDs. I think around 7 or 8 or 10 have worked. Rest, just give a try. Because some of them were engineers, some of them were one-eyed. So in these cases, I think it makes us to at least jump and try to see, rather than going blind, at least give an attempt to see. I have operated 5 times in that closed funnel RD, and still the retina is attached today only with the silicone oil. The second thing is the globe also remains intact. They don't go in for phthisis very soon. Otherwise, it gives a very ugly cosmetic looks also for these kids, especially the girl child. Yeah. Yes, thank you. Thank you. Thank you.
So next we have Dr. Santosh, who would be speaking on biosimilar and ranibizumab, boon or bane.
Good morning, everyone. Like from after Srinivas showed this extremely difficult cases in retina surgery, now we are back with to the day-to-day affairs. I'll be talking on anti-VEGF and the two biosimilar. So most of us are either dealing with it or refer a case for treatment to a retina surgeon. So I think we are in a situation where biosimilars are going to take the lead in treatment of many retinal diseases. So the topic is biosimilar ranibizumab, boon or bane. As we know, biologics, biosimilars are the molecules which are very similar to the original product. So biosimilar is a clinically meaningful difference in terms of safety, purity, and potency, but it is chemically very similar to the original product. And the product almost acts in a very similar manner. But the main point why we want to biosimilar is the cost. So selection of anti-VEGFs is important for retinal diseases, and the financial point is the most important point at this point of time. So, but finance only cannot decide everything. So the drug we are using should be safe, effective, affordable, and we'll all need to have good access to the drug. It has to be scientifically proven that it is both effective as well as not only effective in terms of its action, but also cost effective to be used. So if you talk of the cost, in Indian scenario, these biosimilars have taken a front seat because of the cost factor. And these are the points. In India, 12 to 22% of Indian population are below poverty line. And India's per capita income is around $720 in contrast to US, which is more than 43,000. And treatment costs are not covered most of the time by the insurance companies. And approximately 70% Indians pay for healthcare expenses of their own. So all these points taken together, we are trying to find a agent which can solve this problem. And the approved biosimilars in India now are, first one was ranibizumab, which is been already approved for 6 indications, including wet AMD, DME, RVO, myopic CNVM, proliferative diabetic retinopathy, and ROP. And the others like ranitidine approved for AMD only, Bizumab from Cipla is approved for AMD. Raniase is approved for 4 indications like AMD, DME, RVO, and myopic CNVM. And Oseva from Sun Pharma is approved for AMD, DME, RVO, and CNVM. That means three in biosimilars, that is Oseva, then your Rania is approved for 4 indications, but Rajumab is approved for another 2 indications like PDR without macular edema and ROP. So this goes over others in terms of number of approved indications. Second point is its shelf life is 36 months, in contrast to the others who have 24 months. But again, Raniase and Oseva also have half-life of 36 months. So Rajumab, as you know, is the world's first biosimilar. It has been approved by different authorities. These are the certifications. I'm not going into it. It is well certified and approved by both FDA as well as Indian authorities. So there need to be a scientifically head-to-head comparison between the parent molecule and the biosimilar, which has already been published in different publications, and it is almost being used in major government setups. These are the different publications based on Rajumab, which shows the clinical evidence based on users' experience. And this review article tells that treatment, this macular, this is Rajumab is very effective for neovascular AMD. This is another article which tells us the outcome of intravitreal ranibizumab for chororetinal diseases. And these are the different intricacies. The overall conclusions tells that they have used in this Rajumab in 9,406 patients. Injections have been given in 6,404 eyes, and it is found to be safe. And it is no new ocular systemic septic concerns were found. Another article by a group from mostly West Bengal. This is called Balance Trial. And this is a real-world evidence that this efficacy assessment and safety assessment found that this is both safe as well as effective. This is regarding ROP. As I was telling, this is the only biosimilar which is approved for ROP. And these are the results. The key highlights tells that it can be very well safely administered in ROP with equal effectiveness. And this is another study by Dr. Lalit Burman et al., which tells us clinical efficacy and safety of Rajumab. Our experience with was first biosimilar. This is published in Indian Journal of Ophthalmology. And this is in diabetic macular edema. This is on PCV. And this is the VRSI survey, which all of us have participated. And the conclusions were Indian vitreoretinal specialists are familiar with anti-VEGF biosimilars, and there is a progressive trend favoring Rajumab biosimilar over the other bevacizumab biosimilars. 1/3 of the participants deemed to the current price of ranibizumab biosimilar as appropriate replacement of Avastin. As because we are concerned with the finance part, even it is very appropriate to be replaced by this biosimilar in terms of Avastin cost. Similarly, is the need of enhancement of this pharmacological vigilance and larger clinical trials. So as I have showed different trials which have proved both efficacy and safety, as well as a very much comparable financial statement. So with this scientific data, I would like to show my few experience with biosimilars. This is regarding a case of PCV, where we usually assume that we have to use the parent molecule, but I have used ranibizumab, and you can see that it is showing multiple these thumb-like polyps, which is consistent with PCV. And following injection, these are decreasing here, and this is totally flat retina following injection of ranibizumab biosimilar, the Rajumab. This is another case of DME, where you can see extensive hard exudates here, and it is responding to Rajumab. This is the left eye of the same patient, which is showing a very good response to Rajumab. This is myopic CNVM. You can see here there is a clear-cut CNVM component which has decreased following only one injection of ranibizumab. And this is a case of BRVO with macular edema, with SRF, with cystoid fluid accumulated intraretinally, and it is also showing a good response. So the another case of STVRVO in the right eye, with vision which is improved from 636 to 69, and a completely flattened retina here. So the scientific data as well as real world scenario data shows that biosimilars are not only effective but cost effective, and personal experience also favors the same. So here with this presentation, you people can decide whether biosimilar Rajumab is a boon or a bane. Thank you very much.
Thank you, Dr. Santosh. As we are running short of time and there has been multiple.
I have already adjusted 7 minutes.
I hand over the.
Yeah. That goes without saying. There is commercial interest, because I have been engaged by the company, but I share my experience. Thank you.
With this, I hand over the microscope to Dr. Adnan. Sorry, the microphone is to be handed over to Sashmita. I think the next session is the second part of the live surgery.
Beyond an IOL 700 in a single centimeter. Yeah, the for eye foundation, NN, LVP, nowhere greater.
Yeah.
5 recommendations out there. I didn't get not good.
Sir, can you hear the OT?
Am I audible now from the
Yes.
OT?
Yes, you're audible.
This should be switched on. Inside it's
Sir, can you tell us who is the surgeon and
यहाँ का आवाज नहीं आ रहा ना अंदर का OT की टीवी का आवाज नहीं आ रहा है.
so I invite the panelists for the live surgery session 2. Dr. Sujata Madam, Dr. Ashwini Behra, Dr. Shrikant Sahu, Dr. Sucheta Parija, Madam is here. Dr. Sridhar Maharana.
Thank you, Dr. Sasmita. We would start with Dr. Shreyas here. If you all are ready now, I think we'll switch over to where is Mihir? You are here? Mihir?
Hello. I will share the patient details.
So this is
Dr. Shreyas will doing a case.
8-year-old.
So-
Go ahead, go ahead.
Yeah, I am doing. A 62-year male with right eye vision 20/200 with phenols coming to 20/40 and left eye phenol 20/20. IOP is normal in both eyes. Left eye pseudophakia, right eye NS3. Retina is not that bad. It's have some mild foveal hypoplasia with a small ERM. Rest is normal. And in others biometry, that is 22.5 with not that much cylinder. So here we are planning for a Clarion autonomy. Let's say, Shreyas, please take over.
Oh, okay. You have the microscope view.
This is the eye trace picture.
Am I audible? Is Dr. Shreyas audible there at the hall?
No, we cannot hear.
Can you hear me now, madam?
Yeah, the voice is little low. You can just speak loudly, little loud.
Oh, I'm operating on this.
Yeah.
Gentlemen, what was written in the pre-op file as grade 4 nucleus, but I think it's possibly a grade 3. But the Regalia makes it look as if I'm operating on a clear lens. But that's one of the beauties of this microscope. Has a fantastic red glow, and you're able to do with company kind of. I usually try to aim for something between 5 to 5.5 rexes. So I'm using a 2.4 incision, 2.4 millimeter clear corneal incision. So the reason is, I think this was discussed earlier also when Dr. Anurag was operating, that it makes it a little easier to insert the sleeve, but at the same time, you don't have any astigmatism extra which is being induced. I'm just doing a gentle multi-quadrant hydro. It's always important to have a nice freely rotating lens. Yeah, can I see the screen, please, so that I can have an idea? So I'm using the Alcon Centurion chopper. Small also. So I prefer to use two types of choppers. One which is a little sharper, and the other one which is a little more longer, which is usually very good if you're doing a hard cataract. I'm just making a small groove, bury deeper into the nucleus. Just to ensure that the nucleus is nicely separated. Swipe before I go ahead. As you can see here, it's a moderately dense cataract, nice choppable cataract. Centered, sir. So, is it better now? Align up on it. A little that, especially that joystick to move the this thing is a little harder, a little higher also. So once the Ops are completed, you can go into order. I think that's one of the advantages with all the modern machines with the good fluidics, with the active century, the Centurion, are able to really just stay in the center, not really worry too much about surge, and emulsification is usually very easy. Even the amount of energy required to emulsify these cataracts is quite low.
Good. So fairly hard cataract, grade 3, grade 4, with a CDE of about less than 11. It's an excellent job. What is the reason for giving a viscoelastic before you do a IA?
Probably not needed, sir. I think just out of habit. It's So I like to use this sandblasted bimanual, which also helps you to polish the bag wherever necessary.
The Alcon has stopped giving bimanuals. It's only providing with a coaxial irrigation assistance program.
Yes,
What do you feel?
we don't buy from Alcon. So Epsilon makes it, Apasami also makes it. And but it's good, sir. This one, especially from Epsilon, no financial interest. Yeah, but that's already good. So the Clarion autonomy, and it has the pressing type which you can press and bring the lens into position. The more you press, the faster it moves. That is right up to the group. Nicely loaded by
I have one observation in Clarion. It appears to be a little more tacky than the IQ lens. Sometimes if the booster haptic is holding on the optics,
right.
it really takes quite some time to unfold.
No, that's why I was saying that it's very nicely loaded, because the initial that visco which they put in into that small opening, that is very important, sir. We should neither overfill, which can increase the tackiness, nor do we want to have a very less that the haptic doesn't go on top at all.
Excellent surgery, Dr. Shreyas. So, what would you say about looking at moderately hard cataract? What
Most important is to ensure that it is fully chopped and separated. If the pieces are completely separated, which I think we should spend maximum time with, then the rest of the surgery becomes extremely easy, almost looks effortless like any other normal case. So I think that would be the single most important way. And just for those who are in the audience who are not able to see this, the beautiful modular OT that we are operating in, really top class and has a wonderful background scenery as well, which I don't know if you are able to see. Makes it so pleasant as soon as you enter the operating theater. The entire you feel so comfortable and so nice as soon as you come in. Thank you so much, sir, for the opportunity.
Thank you, Dr. Shreyas. So, after watching this wonderful surgery, Dr. Shreyas, you should act because you are the first person to give the talk post. Okay. Dr. Mihir can probably go about speaking about the second case. Dr. Rohit, Om Prakash will be operating the second case. We have a separate session to introduce all our guests, so I'm not going to tell much about the guest right now. So you have to keep your memory sharp subsequently so that the guests, when they are introduced, you'll know of what stage they are.
Our next person is a 62-year female. Hello.
সে গেট বন্ধ করে দিলা কথা সে গেট বন্ধ করে দিলা গেট বন্ধ করে দিলা এই আমরা নাও বন্ধ এন্ট্রি নেই
Our next patient is a 62-year female with the finger vision of right eye is 20/40 and left eye 20/60. Is having NH3 cataract in right eye and left eye NH3 with PSC. IOP is normal. And there is some cornea gota in both eyes. Retina is good. The specular count, CCT is 489. CD is 3276. It's a good number of cell count. CV is normal, it's less than 30. And hexagonality is 52%. Counts are good, but there are some gutta in the cornea in both eyes. So this is the OCT picture, and this is the variant picture. There is not that much astigmatism. So here we are going to put a 22 diopter, 20.5 diopter, Clarion wagon wheel IOL. Plain Clarion.
27 with 2 CC. Yeah.
So, somebody will drop you. No? Yeah, I'll take you. I'll take you. Just a minute. So what you see here is a iTress reading, and
You have that 2.8.
if you can see my arrow, it says the dysfunctionless index is about 2.2. Anything less than 5 is a bad lens. So you can see the amount of aberrations from the lens, the amount of aberrations from the cornea, and this is the total amount of aberration. This patient has an angle alpha of 0.4. So I would like our analyst there, the eminent people sitting there, Sucheta and Shrikant, to please be more active and discuss the case.
First thing that I would like to speak about this particular slide, sir, is you write about the DLI being poor, and 2.25 is the score that's been allotted. But if you look down below, there is a symbol of a spectacle, pair of spectacles, and you have a cross sign riding over it, which means that this DLI is without spherical and cylindrical correction. What we should ideally see when we're evaluating the preoperative patient under the eye trace is the best corrected DLI, because that will essentially keep the spherical, higher order aberrations coming out from the cornea to be at 0, so that only the lenticular aberrations are unearthed or unsurfaced. There, the DLI is expected to get a little better. This is quite expected from a cataractous lens, but still, we should see the best corrected DLI in every patient. So that's something I just wanted to bring into attention. The other thing is, If you look at the right side of the screen, the tracy refraction is shown to be 0.75 sphere with a 2-cylinder. But a while back, while Mihir was explaining about the case parameters, we saw that there's hardly any astigmatism in the corneal front. The tracy refraction is a refraction that is calculated by the wavefront on the anterior lens capsule. So it takes into account the corneal and the lenticular refraction together. It is very likely that this particular patient was using glasses because the lenticular astigmatism is there. But if you remove the cataract, along with that, the nucleus material, the lenticular astigmatism will be withdrawn, and this patient does not require a toric IOL implantation. So that's just another thing that you must look at when you're deciding based on the refraction of the patient, based on the glasses and the power of the glasses the patient is wearing. You should never ever choose a toric IOL. You should always choose the toric IOL based on corneal astigmatism and not the whole astigmatism as a whole.
To add to it, Anurag, if you see, the higher aberration of the cornea is not also too much. So that goes again in favor that the cornea is not that astigmatic.
Yes, right. And if you remove that cross symbol from the spectacles, you will see that the corneal aberration will be absolutely zero. The E will be very sharp.
As Dr. Rohit start, is Shreyas over there?
Is Shreyas there in the OT or has he left?
Yeah, please.
He is there. Shreyas, you have a question from the panelists.
Shreyas, like it's more for Anurag and Shreyas. What I marked is you didn't actually rotate much.
Sorry,
Anurag,
sir.
you didn't rotate much the nucleus after your hydro.
Okay, sir.
Anurag believes 160-degree, like 180-degree or maybe 360-degree. I also do it little more than what you do. So what do you say, Anurag?
Sir, as long as it's freely mobile is what I'm more concerned about, sir. So if I can rotate clockwise or anti-clockwise easily, even for a few clock hours, then I feel I'm quite comfortable and I'm okay to proceed with the case. And as you saw during the rest of the case, after chopping and rotating also, it seems fairly easy. It's what I usually do, sir. But yes, I agree that there are surgeons who prefer a full 360-degree rotation also.
Yeah, I actually believe in the Vasavada school of thought of rotation of the nucleus kills the lens epithelial cells. Of course, with the advent of the present day material and their tackiness, the hydrophobicity, PCO has ceased to become a real concern in the real world. But still, I rotated just to make an attempt to kill the peripheral ALE cells so that we zero the possibility of PCO postoperatively. We can never bring it down to zero, but at least we should take all measures to cut it down to the bare minimum possible. That's the reason why I rotate.
Some bit of it, not. So, good morning. Can you hear me?
Loud and clear, sir. Please go ahead.
Can you hear?
Microscope view.
Hello, can you hear me?
You're loud and clear, as Anurag said.
Yeah. Well, I'm Rohit from OT number 2. And I take this privilege to be invited by Dr. Anurag Mishra to this beautiful institute of this, which has 2 modular OTs. So it's a privilege to be working here as an operating surgeon on this day of Foundation Day. So I'll be taking up a patient wherein there is a nucleus sclerosis grade 2, and I'll be implanting a Clarion intraocular lens. The machine which I would be using is the Centurion machine. My preferred site of incision is the temporal site of incision. Why a temporal site of incision? Because this gives me the advantage of better access. There is no brow in between. And, there's a less pooling of, the fluids. Astigmatically, it is better. And the red reflex is also, as you can see. Can you see it clearly if I'm permitted to ask? Hello? Is the visibility clear? Is it focused?
Yeah, it's clear.
Yeah. So my site of incision is going to be at the limbus because that would give me a faster and a stronger healing process. So I'm going in. The next step is introducing the visco. I'm going to, moisten the cornea. No. No, take your time, take your time. I'm in no rush. Like it and देखिए ma'am. See how I'm introducing the visco. I'm going right in so that we have a good interior chamber. Side port. Incision which I give is the calibrated side port incision. It's a 25 gauge needle. So now this is calibrated to my, chopper because this is 500 microns and the chopper which I use is 400 to 450 microns. Capsulorhexis I prefer to do with the Capsulorhexis forceps. I'm going in, creating the initial nick, holding it, going around again. They're almost there. Could you see the rhexis being completed? Was it clear? Can you hear me?
It's very clear.
Hello?
Hello.
Can you hear me?
We can hear you, sir.
Hydrodissection I do with a 27 gauge cannula. I'm going in, waiting for the wave. Now it will come, a slight nudge. Visco again. I'll try to zoom it more. Use this thing, nudge it. So I'll be using, use the balance tip because this gives me the advantage of better stroke length and lesser amount of wound site thermal injury.
You're using a 20, sorry, 2.8
Yeah.
sleep.
Yeah.
In resin banded, it's not hard cataract.
It's just that I, at times like to use it. This is the chopper which has gone in. I'll be doing sculpting here. Let me focus it first. Is it focused? Yeah. I want to create a valley. Quadrant. Can you see the chop? I'll rotate it now. Using the torque to my advantage. Put position 2, 3, back to 2.
You trains in all cases, only cases.
Depending on the situation. Stop it. Leave it in C2. Put position back to 2. Could you see the chop?
Yes, sir.
No?
Yeah.
2 back, 3, 2. Chop it completely because it was grade 3. Much more than what I had expected. Separate it fully. Now I'm going to show you a small trick. How I'm going to protect the endothelium. What I'm going to do is I'm going to do mechanical dissociation. Can you see this? No, I'm not able to note it. total separation. This is the nuclear core. Pull it. I separated the nucleus from the epinucleus. See it again. Can you see it? Just see again. Separating it. Could you see how I'm separating the nucleus from the epinucleus?
Yes, sir. We could see that.
Again, separating it. This is allowing me to work at a deeper plane.
All along, you're maintaining the epinucleus cushion for the PC. Is that the idea, sir?
So now I am left with the whole epinuclear sheet. The IOP at which I am working is 28.
$28 with a flow rate of 40 max panel.
How much is it?
It's 40. 40. And the vacuum is now 450 panel again. No threshold. Wonderful. The stability is impeccable. And I also see that you did have your IP switched on while chopping.
Can you see the size of the pupil is the same as it was at the start of the surgery?
Absolutely.
It is because of the calibrated side port incision, which was not allowing undue flux of fluid from the side port. Can you give me visco? I think it's, I'm using this microscope maybe after ages, but I tell you, it's perfect. I thought that I was working in my own operation theater on that Lumbra 700 with that RT work.
Dr. Rohit, the case was mentioned there are gutty in the cornea. So what viscoelastic you are using? Can you tell?
I'm using hydroxy propyl methyl cellulose. I use the IA with the coaxial one, and I use the double hand coaxial technique. I would like these people, when it is focusing, it should focus on my hands also, because what I would be doing for I use a, what do you call, a curved one. My indication for using a bimanual is when there is a subluxation, when the PCR is open, that is the situation wherein I use a coaxial bimanual IA, but for other, is it okay? But for other purposes, I use a coaxial in practically all the situations. Okay, so this is the curved one. Can you focus on my hand, sir? I'm using both my hands. This will help me in doing the subincisional one. I'm using, just see how I'm moving my hands. Can you see my hands too?
So the sleeve you're using is a 2.8 millimeter sleeve, I guess.
Yeah.
Okay. Is that something you always use, or
Not at all.
in cases do you switch?
Yeah, it's just, so it's, see how I'm rotating it using both the hands. So it is done. And you will see that the size of the pupil is the same as it was at the start of the surgery. Visco, yes. Do you have trypan view or trypan view है आपके पास? या मुझे बाद में दिखाना जब मैं कहूँगा. So this is not the preloaded one. This is with the plunger one. Okay. Okay. The straight one. Yeah, no, the straight one to fix it. Yeah, both sides. Why on one side? तो अंदर दूसरी तरफ करें. कोई बात नहीं, I'll use it. Light तब देखिए मैम. So I'm going to implant the IOL. I don't use plunger somehow. Why I don't use the plunger? Because I've had, then I was, नहीं ये नहीं बेटा कुछ और दो. No. The straight one. Yep. Well, just push it in. So there it is. So it takes time to, uh, the what do you call the haptic to release. I use the backbends technique to take out the visco, wherein I just rock it. I, do not go behind the IOL somehow, because once or twice I had, rupture. So, but then I've started using, the backman's technique of rocking left, right. To take out the visco from the interior segment. Yeah, I need to do the stromal hydration. Can you give me the Trypan blue? Trypan you have? 2 ml से ले सकते हो आप? नहीं है. For stromal hydration.
Dr. Ashwari, would you do anything different if you see the endothelial gutted in the cornea? Would you do anything different?
Can you see there is the side port is healed, it's self-sealed. So this self-sealing, shows that, this makes me believe that no patient has any leakage, because at times we find, we do sedals in all the patients post-operatively on day 1. And we used to find lots and lots of side port leakages, which have finished once we have started using, smaller one, which is hardly 500 micron. And I think I'm done with it.
Dr. Rohit, even without using a blue, just shallowing at the antechamber or the pupil becoming smaller is also an indication that the leakage is still persisting.
Yeah, absolutely. That is also one indication. But then, why I'm not using, another reason why I'm not using bimanual, because I'm not able to calibrate it to a smaller size. And why to have more incisions? I think using a calibrated side port incision is a very important step, which we at times, tend to overlook. Nevertheless, I'll be doing it, because with this, calibrated side port incision, if you're not using a calibrated one, at times in patients on tamsulosin, the intraoperative floppy iris syndrome gets precipitated because of, iris coming out through the side port incision. So that is one thing which, that is one thing which is often overlooked, the calibration of the side port instrument. So by all means, I would suggest that each one of us in our endeavor into, cases should definitely try to calibrate the side port instrument, whichever he or she is using, and calibrate it with the side port incision. That helps in, further improving the efficacy of active fluidics with the active sentry. With low IOP also, you can use, with even as Dr. Anurag has shown at 20, my indication for using 20 is only in those patients of posterior polar cataracts, in patients of high myopia for 20 millimeter IOP I'm talking around, and in patients who are on tamsulosin. So these are the patients where I use physiological IOP, because I want stable chamber settings. In patients with posterior polar cataract with pre-existing defects also, because when you are using low IOP, what you are doing is there is less infusion of fluid into the anterior chamber, and there is less, posterior bulging of the posterior capsule, less hydration of the anterior hyaloid phase, and the probability of the anterior hyaloid phase getting broken, even in the presence of an open posterior capsule rupture, that decreases. It has been shown by a study from Vasavada that with high IOP pressure which is being used, at times with an intact posterior capsule, you end up with a situation wherein the anterior hyaloid phase gets broken. So using low IOP has been one of the best things. I think I would like to say that Dr. Anurag Mishra was one of the initial ones who showed me how, he used to use even a pointed chopper for all the patients. So he was so clear about the stability of the, anterior chamber. But I somehow, use 28 in all my routine patients with 20, as I've already told you.
Right.
So one more question to ask you. So there was a discussion that hydrodissection should be done. So I observed that you didn't do a hydrodissection, but did a very good chopping procedure. Can you just throw a light on that?
Yeah, I do hide because what I am doing is I am taking into advantage. I just see a wave which should be there. The moment I find the wave is there, the only thing which I do is I just press it so that the required effect is there. I do, and you have problem in rotation if you are doing direct chop, and if you're not able to create a chop at the position. What I do is I take the advantage of the chopper. I take it right near the capsular axis margin, and with the mechanical, rotational process, I'm able to rotate the nucleus. I don't find any indication for rotating the nucleus prior to doing the sculpting or whatever it is, because it is only in extremely soft cataracts in younger individuals that I do hydrodissection at different places, because there are stronger capsulocortical adhesions. So that is the thing which I do. I just rotate it prior to that. That is the only condition where I use it. I am not doing direct chop in all the patients because I feel there is something called horses for courses. In my practice, for soft cataracts, I use the rapid technique. Then I do stop and chop. And in grade 5 cataract, I just create a small crater in the center, and then I do the chopping with the, what do you call, a pointed chopper.
Okay, nicely done, sir.
Excellent. Hello.
Hello.
There was another question about dealing with patients with Gatata. So you did not do a soft cell technique. Probably is it because you were sure that the cataract grade was not significant and you can handle without a soft cell technique, or you feel even without a soft cell or viscode being used?
Yeah, what I do is, I don't know whether you saw what I did. There were a few tricks which I used. I have started in somewhat harder cataract as this was. I was doing three things. First of all, I had divided into smaller fragments. Then I was doing mechanical delineation of the nucleus and epinucleus while I was chopping. What was happening was I was creating an epinuclear shield. Now, what was the epinuclear shield helping me? It was helping me by three things. It was a posterior epinuclear shield. Then there was an anterior epinuclear shield. This was allowing me to work at a deeper plane, smaller nuclear fragments, because the epinucleus had been separated. So this helped me creating a situation where I have crystal clear corneas right on POD1. Viscode is has a very limited use in my practice. I think it's more at working at a deeper planes, dividing it into smaller fragments, total separation, and that is the way I do it.
Yeah, you all your FECO in the bag only.
Yeah.
And the CD is very less. Good job. Any experience about Clarion lens?
Sorry?
Any experience about Clarion lens?
Yeah, I have used it not very often, but the number of patients which I have used it, I find, that even for the near vision, intermediate vision, it is helping the patients.
Okay, thank you, sir. Nice done surgery.
Thanks.
The next case will be going to surgery will be done by Dr. Pathliswas, and he will be doing a surgery in a patient with 62-year-old female with right eye vision 120, with pinhole it's 26 to 60, and left eye pinhole vision is 20/20. IOP is normal in both eyes. Right eye is having NS2 with PSC, and left eye is already having a multiple lens. Retina is with the normal limit. In August biometry, the K1 is 44.07, K2 44.99, with a cylinder of 0.92 at 87 degree. But the expected post-operative expression would be minus 0.34 diopter with plus 0.5 cylinder at 85 degree. So there is no need of any toric in these cases. So here we're going to put a Clarion Panoptix. Sir, it's up to you, sir.
Thank you very much. Thank you, Mayor, for the kind introduction of the patient. Thank you, Ashok. Thank you, Anurag, and the whole team of CarVision. And it's wonderful to be back again in Bhubaneswar, the land of Jagannath, and with the grace of the Lord. The wonderful surgical exposure that we have been seeing throughout the morning is really heartening. So this is our case, and Mihir has very nicely suggested what we should go ahead with. And so very on off, please, at the moment. We'll make 2 side port incisions, and these Maji, सीधा light को देखिए, light को देखना है. So the side port incisions are 1.2, and the beauty of these incisions are, and when it is specially made by these particular blades supplied by Alcon, no financial interest, they post-operatively, you can hardly see the incision. And our patient is also very, very cooperative. We'll put some anesthetic, intracameral anesthetic, and some trypan blue. And of course, the Revelium microscope is a beautiful microscope. All throughout my life, I've been using the rice form for the microscope, but the Revelia has a lot of promise, and the wonderful red reflex that is there is really, really heartening. Yes.
So I would begin with a very elementary question to you, sir. We just saw the biometry of this patient, and this patient has been selected for a trifocal IOL. With a 2.5, the spherical equivalence that was residual was minus 0.09. And the 22, the spherical equivalence was plus 0.27. So as a principle, when we are selecting patients for trifocal implants, should we choose the first minus or the first plus as the spherical equivalence residual in the post-operative period? What do you do in your practice?
I would suggest that we use the slight minus. That's the promise that we have made to the patient. That patient would see well for the distance, for the near, as well as for the intermediate. So the minus is what we would go in for. And however, of course, if it is the second eye, we need to see how the patient is behaving in the first eye and take a call on that.
Suchita ma'am, what would you do with a trifocal implant? Would you take the first plus or the first minus?
I take the emetropia, neither.
The emetropia was not a choice here. It was between minus 0.09 and plus 0.27. Equivalence.
I'll take the plus.
You'll take the plus. Any reasons why?
I'll take minus because at least light myopic is better than hyperopic.
Ma'am, what's your theory behind taking the first plus?
Yeah, mainly it's like we needed that they have a near vision. So at least the near vision distance with a plus can be, and distance anyway is corrected with it. So that's how I have seen some of the cases, but I don't have much
All right,
of
so
it.
let's see a rise of hands then amongst the audience. Let's take a vote. How many of you would choose the first plus amongst the users of trifocal? 1. And the first minus? Many? Right, so PV sir, you have more supporters here. Unfortunately, I'm not one of them. The reason is, when you get the halos naturally coming in from the design of the trifocals, If you take the focal point away from the fovea, the halos will be magnified. You take the first plus and recede the focal point behind the fovea, the halos will be that much less. So if you want to spare your patient from a potential photic phenomena that can happen in the postoperative period with any trifocal design of any sort, it's always better or safer to stay on the first plus than to go on the minus side, because these foci are so brisk and clear that even if you leave them first plus, the intermediate and near vision will still be at a point where the patient will not be complaining.
The other reason, Anurag, is we are promising more for near them, because the patient who go for multiple, they're going for near. So, and we add +2 or +3 as a, you know,
2.25.
no, right. So we add 3. So if you give a myopic one, that it becomes a little less. So they're not very happy with the near vision. So that is why that was the first initial thing why we should give it a more little on the hyper side for the trifocals. For the EDOFs, the whole thing changes.
EDOF, that's the whole thing.
The whole thing changes. Then become little myopic. In those conditions, it will little myopic. But trifocals and multifocals is little on the hyperpic, makes the patient happier.
Okay, shall we proceed with so this is a grade 2 cataract, and of course the Revelia shows it as if it is a grade 1. So we'll go on and try and do a straight chop for this patient. So what is very important is there should not be a kink at the site of the incision, otherwise you might have a little bit of a problem. And so we go right down here.
So you don't use IP while chopping?
Have they given IP? So even a softish cataract you can get through very well with a straight chop, and a direct chop gives you the advantage that the amount of echo energy is less, and it's important to see that it has come around and the whole chop is complete. Can we have the quadrants, please? Grade 2, please. Grade 2 setting and quadrant. Yeah. Okay.
I think with all the three honorable guests of ours, what we have seen common in the parameter setting is the vacuum is not, it's barely beyond 400. So what it tells us is with very efficient machines which have excellent fluidics, you actually don't need to jump into the 600 plus 700 range anymore. You can do a fair bit of job even with a vacuum setting low and
so it's a very well maintained intraocular pressure, and the patient is also quite comfortable during there's hardly any surge there. Of course, as we come to the last part, we can go into the epinucleus mode and make sure that we are very safe epinucleus.
Now, Partha, what is the threshold for toric in multifocals? Threshold.
Yeah, so here, of course, we definitely need to check on the posterior astigmatism, and so one definitely, and of course, taking into account the posterior corneal astigmatism, 0.75 and above. So that is very important for the trifocal, because the trifocality depends upon a great deal for the astigmatic aspect. And because the importance of having both the eyes trifocal is also important. So, Mr.
Sir, hello, sir. Sir, just one question, sir. During the procedure, I could find that the direction of the bevel was throughout the procedure which was downwards. So, can you just tell us about that, and should we do like that, or?
Yeah, so the bevel downwards is when, because I can see the bevel very well. And up to what I am sure that I'm safe with the deep part of the bevel. So that is the reason the bevel downwards. However, I always keep rotating the phaco tip to the advantage. If I want to grab a piece, I usually rotate it a little on the slant so that the grab as good as possible.
Yes, that's a very well point made, Sridhar. If the bevel is towards the side, the nozzle would operate vertically. And if the nozzle operates vertically, then the followability is much better than if it operates horizontally. It's you can say that technically it is a little difficult to rotate it intraoperatively. I mean, you might not remember to do it most of the time, but if you are managing to do it as Sir exhibited in the last case, I'm really thankful to you to notice that and bring that to the forefront. It actually serves very well. So we are ready to plan.
Based on the Panoptix lens, this is a real favorite of mine, and it is stood the test of time over so many years now. So we'll do a moon assisted, and Rajendra has very nicely loaded it for us, and it goes in very, very well, and snuggles in extremely well. So removal, this is so we could see a small fragment of cortex there. So as here it is, so we have brought it off, and removal of viscoelastic is not required. So for all single piece lenses, this is my preferred choice, the wound assisted, and a good envelope of the Rexis 360 degree, and that would give a very, very good sensation. We had seen the kappa in this patient, it was just about 0.3. So with a good kappa, the patient's trifotality should be quite good. And the patient, this is a second eye. So the first eye also has a trifocal. And
so from a performance standpoint, do you find any difference with the Clarion Panoptix from the Acrysoft Panoptix? Is there anything even meager, even minor? Is there anything on the performance standpoint? Do you find?
Anurag, actually, 3 of my patients had a Clarion Panoptix in one eye, and Acrysoft Panoptix in the other eye.
It's exactly, yeah.
So, asked them about any difference that there. All of them were 6, 6, and 6.
Yeah.
2 of our patients on questioning said that yes, there is a little difference. I feel more comfortable. That is the word that they say. We did not want to ask them leading questions. They said that I feel more comfortable with the one that has Clarion, comfortable of the vision. So we just left it and that. Didn't want to probe too much about it. Otherwise, we would end up explanting a good panoptic Acrysoft with a Clarion. So, but all said and done, they match very well. They are very good lenses, and Panoptix has really been in one segment that is extremely good. And we really have this vision for our patients who require the intermediate distance and the near. Of course, the contrast sensitivity and the little bit of photic phenomena is something that we have to explain to the patient pre-operatively.
Yeah, actually,
Let me put the message for the patient.
usually patient say it is better and because
Thank you very much. आपने cooperate किया जी.
of months
old. You're not transmitting there, sir. I think he's not able to hear you. Sir, can you hear me?
Yeah, sure. Yes,
Yeah.
sir.
Me? No.
I cannot say a no to that.
Yeah.
So I said, Parthada, the second eye is usually a month or 2 months old. So when you ask the question, the other eye would have been 5 months, 6 months old. So obviously the second eye would be brighter and patient would be more comfortable comparing with the older eye. So that could be a reason, of course.
Always, Anurag, not always Ashok, because once in a while, they will say that, no, my first eye is still good and this eye does not. especially this happens if there is astigmatism which has either been induced or an astigmatic component is still present. So we have to take care, especially for trifocals, that the astigmatism is as minimum as possible. And with all the incisions that we have, the expertise that most of our surgeons have, SIA has gone down to 0.2 and 0.3, which is nearly negligible. And of course, these markerless systems work wonders, and, not only for the capsulorhexis, but also for the toric. And it gives a lot of convenience for our patients. And the accuracy factor has gone up tremendously. However, if a markerless system is not available to anybody, it doesn't mean that you should not do torics. You can definitely do torics, and we have been doing torics for so long now. It is forgiving at times, but of course, the alignment, the marking, even manual marking has to be as accurate as possible. And this is usually that can be done. So,
Sir, excellent surgery. Can you hear me, sir? Sir, wanted to know in every cases, do you need the variant to do the capsulorhexis, or what is the actual size of your capsulorhexis in cases of multifocals and especially for multifocals and trifocals? Yeah.
5.5 is what we adhere to as much as possible. And of course, even, I mean, we would like to use either the Varian or the Callisto, any of the markerless system for the Rexis marking. I was a great proponent of marking on the cornea also, and I still adhere to this whenever our fellows or residents are doing surgeries, because it gives a lot of importance to the accuracy of the capsulorhexis, which is important, and it needs to be as accurate as possible so that the overlap on the lens is good. So this is something that should be done, and of course, as with experience, the good and round capsulorhexis is a rule. However, for people, and especially if there is an expression of the viscoelastic during the capsulorhexis, it can go a little haywire, and you can lose the centration of the capsulorhexis.
Thank you, sir, for this importance, because I had learned how to do the capsulorhexis. You had taught us those things of marking the cornea and doing it so a long way back. So that is what I wanted to emphasize more on someone who is learning trifocals recently. Thank you, sir.
What she very subtly said is, you have taught someone who is teaching many now. So that's just
I'm honored. Thank you very much. And I must thank the whole OT team for an excellent coordination. And they were hardly speaking at all, and everything came around. And Rajendra, who has been assisting me, put a focus on Rajendra, please. Rajendra was excellent during his assistance. Thank you very much, Rajendra. And sister here also has been doing an excellent job. And the whole OT team, the coordination is excellent. So thanks to CarVision, thanks to the whole team for giving this opportunity.
Hang on, sir. Stand by. We are not done with you.
Okay.
I'm sorry.
In the OT.
Anything to ask? Interject, opine, whatever. Anything regarding anything. I mean, pertaining to ophthalmology, of course.
So one thing that, maybe I would like to say about the machines that we have today in our armamentarium, all of these machines, whichever company is manufacturing them, they are excellent machines. And but the utility of the machine comes in when you actually sit with the application expert of the company, and they help you get the best out of the parameters. Because I was very uncomfortable switching from Infinity, which I love from the core of my heart, to Centurion. And the first 20-30 cases of Centurion, I thought that this is an inferior machine to Infinity. But that was not true. That's not true at all. And it's the use of the parameters to the best of the advantage that makes it so good. And the clarity of the cornea next day, even in hard cataracts, even when you have not used much of the high molecular weight viscoelastics to coat the endothelium. These are great things, and that's what makes not only the surgeon happy, but also the patient very happy. Also the IOP control, and that's something that has really changed the way we are looking at things. At one point of time, we would put the bottle height right up to the ceiling and work under good pressure and do a great job and finish the cataract surgery very fast. But now, of course, with IOP control, so it just needs to be adequate to do a good job. And that's something that we have relearned now. And I think these high-end machines make it very useful for our fellows and residents because even their chance of complication are much less. So it's important to graduate to the better machine with the better and which is safe for not only for the surgeon but also for the patient.
Hello, sir. I have a doubt. Basic. If you have a basic keratometer, what are the tips and what should we be careful while doing a toric implantation?
So a basic keratometer again will definitely tell you your all the parameters that you need to know. But of course, if you're doing a toric, it's very important that you use the optical system. And that is something that, you know, whether you have the highest end microscope or whether you have the highest end of the phaco machine, that has to come in, I feel, earlier because it's the surgery is definitely technically important. But what is important is the technical outcome of the surgery. So the biometry with the optical system has changed so much. And the expectation of the patient, and especially the use of the trifocals or the use of the ADOF or the toric, definitely, you know, you have to look at an optical biometer. And the optical biometers come in all ranges. They are not very expensive now if you consider the volume of your load. And but it is going to give you a large dividend at the end of the road. So an optical biometer 100% is what is a requirement. And there are so many optical biometers in the market today. Not necessary that it should be the most popular one, but each one has its own values.
Sir, one question here, sir. Actually, many of the people do SICS.
Yeah.
What procedure, what particular step is very adequately to be done when a SICS surgeon is going to implant a multifocal or a EDOF lens?
Right. And the SICS surgeon is transforming to the phaco, is it not? Your question, is it not? How does the SICS surgeon go ahead and do a phaco?
No, sir. My question is how to what an SICS to focus upon his steps where he can put a multifocal or EDOF lens for patient satisfaction.
Okay, fine. Yeah, that's a very pertinent question in today's scenario. And we have excellent SICS surgeons who do their extraction of the cataract in small incisions. And their SIAs are extremely low. So it depends upon the skill of the surgeon, the technique that is getting employed, and of course the grade of the cataract, your opening. So all these things go ahead, make it, usable. I would not say the accuracy would be very high because again, your choice would be a little limited. Very hard cataract might have some induction of astigmatism. So all these things taken together, SICS with either EDOF or trifocal, definitely you can go ahead and do a toric as well. But what is more important is the accuracy of the outcome. Accuracy becomes much more true if it is phacoemulsification combined with the trifocal as well as the EDOF. So I definitely do feel SICS definitely has the place under the sun. And however, phacoemulsification with 0.2 millimeters in picture definitely is more accurate when it comes to the highest patient and to the trifocals as well as the oxide.
Thank you, sir.
Anurag, you've gone off to sleep.
Sorry, sir.
Have you gone off to sleep or should I come back?
You are allowed to disembark from the center stage at the moment. We'll have you back in 15 minutes time from now. Meanwhile, Sashmita, can we proceed to the next segment?
Immensely for the opportunity. Thank you very much.
Thank you so much, sir. So next in our platter is the non-ophthalmic talks and a very interesting talks. I would invite Dr. Anuradha and Dr. Sangamitra to give the introduction.
Good afternoon, esteemed teachers, seniors, and dear colleagues. So I'll talk about briefly about Dr. Shreyas Ramamurthy. He stands as a preeminent ophthalmologist. Currently, he is serving as the director of the Eye Foundation in Coimbatore and its other 20 centers. His expertise encompasses advanced corneal transplant procedures, ocular surface surgeries, keratoprosthesis, and refractive surgeries. Throughout his illustrious career, Dr. Ramamurthy has garnered numerous accolades and distinctions, along with several best papers. He has 32 major publications in peer-reviewed journals and reviewer for several prestigious journals. Driven by an unwavering passion for excellence in eye care, academics, and research, Dr. Shreyas Ramamurthy continues to be a leading figure in the field of ophthalmology. I would like to call upon stage our state president, Dr. Subalkara sir, to facilitate Dr. Shreyas Ramamurthy. Sir, please. So Dr. Shreyas will be talking about creating an ophthalmic practice.
Thank you so much for the very kind introduction. And at the outset, I'd like to thank Dr. Anurag and Dr. Ashok sir for having me here all the way. It was a real pleasure being here, being part of the meeting, starting from yesterday's evening gathering to today and the live surgery. All of them, it was a real pleasure operating in his wonderfully equipped theater. I was just telling sir that, you know, I'm yet to see a practice which has an Anterion, an Argos, and IOL Master 700 all in the same place. And that's probably the emphasis that is being placed on quality here. Truly honored to be a part of this. So I have been given this topic of building on an ophthalmic practice, what we could do to get started, what are the steps that we can take on, and to speak a little bit in detail about the digital marketing aspect. I see a mix of senior consultants and some young ophthalmologists as well. So I hope to cater to the needs of everyone to the extent possible. So it always is a tightrope walk. I mean, when you finish all your education, and I think I was just telling Ashok sir also yesterday that 11 years back, I was here in Bhubaneswar, I think in 2013, for a LVP meeting after my fellowship. And the thoughts were very much there on what should be the next step. Of course, I was going to join Eye Foundation, no doubt, but what should be the ideal thing? If for all of us who is starting off, are you looking at joining an institution and building your experience there? Do you want to start your private practice, or do you want to equip yourself further and possibly do a fellowship, possibly do a foreign education? And I truly believe that is also something which is extremely important, that we equip ourselves with all the skills and talents before we dive into a private practice. Because once you've gone into a institution or a practice, your family needs, everything comes in the way of actually going about further training. So it's important that we gather all the training and experience. Then the next question comes whether you want to settle in a big city or a small town. Believe me, please choose a small town. And yes, I mean, I consider Coimbatore a small town. I consider Bhubaneswar also a small town. And what I'm trying to say is that the opportunity which exists in these areas, in the tier 2 and tier 3 segments, is far more than what exists in tier 1 and metro. While the people want to go into metro cities, but the opportunity to make a name and make a space for yourself in ophthalmology is very much there. Can we do volumes from smaller places? Look at Arvind Eye Hospital, Madurai. Look at Chitrakoot. Look at Disha Eye Hospital, Barakpur. All these are probably some of the largest institutions in the world and are all placed in, started off in very small cities and towns. And it's really an opportunity which exists in these locations. Next question comes, if you are starting a practice, whether you want to take on a rental building or you invest in in a land, in a building. While there are pros and cons to both, the going on your own approach definitely involves a high degree of capital. Your property actually gets locked. If you had money, you could probably, you're better off investing in a land somewhere else, which you can sell later. But when you make your hospital on that, being ophthalmologist or being a doctor to the core, you'll never be willing to sell that piece of land where your hospital is built. You have less flexibility. If you want to move to a slightly larger space, you probably don't have that. All these options exist when you're starting off with a rental. And if I had to choose between equipment versus establishment cost, I think it goes without saying that it would be right to invest in the right equipment first, rather than spend too much on establishing a practice and not have enough capital for investing in good equipment. Once you start off, whether it's a rental or a own building, planning ahead, fixing a template for what you require, the number of consulting rooms, optometry lanes, and believe me, this is not something which you're going to use for the next 6 months, 1 year. At least for the next 10 to 15 years is what you have to plan ahead. And what is it that you aspire to be, how your practice to be set up, and what are the requirements that you would want to? Spend a lot of time going into the details, into the planning, into each of the way you're going to orient each of these things. I'm not going to go into the depth of the entire planning. That could be a separate talk in itself. But spending adequate time on getting this done, because this is something which we are not taught right through our education. And how do we go about fixing the right size, the right place? So visiting a few hospitals, maybe looking at different practices, seeing what is working for them, also gives a great start for you to have a clear mindset on what should be working. Ophthalmology, while cataract is important, and while we've been discussing about is cataract right through the morning half, ophthalmology is not equal to cataract surgery. And this is essentially important because for you to create an identity in a new place, in a new surrounding, if you're starting off a practice, you need to do certain things which are a little beyond what is commonly being done in that place. At least for me, starting off doing good amount of ocular surface work, K-pros, mucus grafts, DSEC, DMEX, all these things helped create an identity, create a name. It might be different for each specialty, but it is important. This may not be your bread and butter. Your bread and butter would still be cataract, would still be other things. But doing these things, talking about these things, projecting about these things in meetings, conferences, in your surrounding locales, in your local ophthalmic society meetings, is what eventually helps in garnering respect. And it is this respect that can help you develop a referral Dr. Bastian. There are people who I know, my own friends, who are today doing only a cornea practice. They don't even do a cataract. So to that extent, and they are doing extremely well. They are not just surviving, but they are doing extremely well. And it's only because they have been able to meet personally with a referral Dr. Bastian around them, ensure they develop the trust, that confidence. And this personal communication is what helps in really building up that referral practice. Reaching out to the community is extremely important. While we will talk about digital as well, but even physical ground level marketing to reach out to your public is extremely important. And it's not just restricted to the large NGOs for doing large camps. Even a private practitioner, even 1 or 2 doctor group practice can have a dedicated 3 to 4 member team where you do go about doing camps on a consistent basis. It need not, and camps does not equal to cataract surgery once again. School screening, camps at colleges, camps at different places ensures that there is a certain awareness created about your practice. And while these patients, this footfall may not really generate much revenue, it creates a significant awareness about your hospital and the rest follows. Getting your team right is extremely important. Specifying roles for each of your team, giving key responsibilities for each of your team, whether it's your front desk, your optometry team, counselors, patient care coordinators. Extremely important that we ensure there's sufficient communication happening, sufficient chair time spent outside of the doctor consulting room as well by various team members in your hospital to ensure that they are able to connect with the patients and the patient has a pleasant experience from the moment they step into the hospital to leaving. For a tier 2, tier 3 city, possibly you may have to pay well because again, the getting right talent in a smaller city, smaller town might require that you may have to pay a little bit extra to get a very well-trained optometrist. So ensure that you train your staff well, pay them well, and there is absolutely no replacement for a skilled optometrist because a skilled optometrist in your team can take on multifarious duties. In fact, our entire team of counselors across all our centers are essentially trained optometrists. So in many ways, when they are counseling and educating a patient about various aspects of the surgery which they are going to undergo, the various packages, the patient truly feels that they are talking to a doctor and there is a clinical angle with which they talk. When they are explaining, let's say for a toric IOL or talking about astigmatism, it's not just about selling the product. It's really about explaining to them about what is necessary for them. And that is extremely important. Again, when you're doing the counseling or communication, use of adequate video aids, visual aids. Again, we don't want to scare the patient by showing them a live surgery, but some animations explaining why you are asking them to choose a particular product goes a long way in ensuring that the patient makes the right decision. And cost is not the only factor in ensuring that that is the decision. If they are well educated, they'll probably go for a product which they might have not been ready for or with the mindset with which they came in when they first arrived at the hospital. But this adequate education would help them going forward. Addressing dissatisfied patients is extremely important. Ensure that if there is a patient who's unhappy, who's shouting outside your consulting room, the first thing that we must do is isolate them and ensure you take them to either a counseling room or a manager's room or into your own consulting room, address the complaint so that this does not filter through across to the other patients who are in the waiting hall. So while some of them may feel unreasonable, it is our duty to ensure that we reason even for the unreasonable doubts, we explain to them, and it's important that the patient feels that they are getting value for what they are paying for at our hospital. And it's okay to say that we are a noble profession and all that, but today hospitality is expected not just from hotels but from hospitals as well. And at the same time, they want it at a fair value, at a fair price, and this is how the market is right now. While you have a wide array of international companies who give excellent products, but there are very nice and good products from Indian companies as well. And while it's important for us to ensure and educate the patient that they are not necessarily making a huge compromise when they are going in for, let's say, a premium IOL from an Indian segment. If the patient is finding it difficult to afford an imported segment, we must give that confidence that even with an Indian segment, they can do that. And obviously, you can do it at a lower price, at a lower package. And this benefits both the doctor, the hospital, as well as the patient. Being involved in academics, having your own internal meetings with your doctors or local CMEs, local meetings is again extremely important to ensure that you get the word out about your own practice. So getting more into a little bit of details about the practice and digital marketing itself, everything starts with having an appropriate